terms, I'm thinking, are we dealing with true ataxia, or are we dealing with maybe weakness or something else that that leads to loss of balance, but it's not exactly ataxia. And when we talk of ataxia, I think the few categories of ataxia that I know are sensory ataxia and cerebellar ataxia. So I think more details will help me clarify what exactly we are dealing with. If at all, I'll be able to know what's going on. So maybe let's hear the HPI.
Yeah, so that's a good start. And so she woke up 2 days ago with loss of balance, but the relatives report that a day before she presented to my hospital, she went to bed just fine, and so she required assistance to walk, otherwise she would fall. And the daughter reports that her speech was like that of a very drunk person, but she denied focal neurological weakness, fever, or AMS, headache, or head injury. That's very short HPI, David.
Okay, let me see that slide. So I'm seeing two things there. So this patient, I think this is a brief history. This is a two days history, and the patient woke up with a loss of balance 2 days prior to presentation, and but she went to bed fine the day before that, requiring assistance to walk. Otherwise, she falls, and then her speech is like that of a very drunk person. So speech is also involved. But otherwise, no focal neurological weakness, no fever, altered mentation, headache, or head injury. So I think this information is helpful and very serious when I say do not have a very good approach to loss of balance. But uh, there's a number of things that I think about here, and with my limited approach to loss of balance, I see that the patient has loss of balance and then the speech is also affected. So, but otherwise we do not hear other weakness. So I'm I'm convinced to direct these things, especially to the cerebellum or adjacent structures that can affect both the speech and balance. So if we are talking of cerebellar ataxia, there is also cerebellar dysarthria. So that's what I'm thinking about now. I think that was too early to localize where this is. Physical examination will help me clarify that. But then, so we are dealing with something that seems to be in the territory of a neurological disorder. Now the question is, what are we dealing with? So looking at the time course, it's been a 2 days history, but this patient went to bed fine and then woke up with this problem. So we are not sure exactly at what point in time it happened. But so I would say, although that may not be 100% accurately guided, but then this sounds to be something vascular until proven otherwise, because the patient went to bed fine and then she wakes up with this loss of balance and then a speech abnormality. So I think examination of the background will help me to clarify if this patient is at risk factor for any cerebrovascular event. For example, if the patient is hypertensive, if the patient is diabetic, or any other relevant past medical history. So yes, at this point in time, I think I'm more inclined to think that this is a vascular event, and the vascular event is probably involving the posterior circulation, especially at the level of the cerebellum, leading to cerebellar ataxia and cerebellar dysarthria. But I think because of my limited knowledge, I've closed in very quickly. So examination and other details will help me. Other components of the history to begin with, and then examination and other details will help me refine my thoughts. So I think I have other possibilities that I'm thinking about, but then we can just proceed.
Sure. So, review about the system, GIGU, nothing significant. CVS, nothing significant. In respiratory system was also normal. Past medical history, so she has hypertension, chronic low back pain, bilateral knee osteoarthritis, but she didn't have any previous surgeries. Her meds included Ibercetin H, Esamlodipine, junior aspirin, Torvastatin, meloxicam, pregabalin, and joint support. Family and social history. She's a widow. She has 7 healthy adult children. She's a lifelong non-smoker. She doesn't drink, and she doesn't take any illicit drugs. Anything there?
Okay, let's start with the review of systems. Yes, so first of all, in the HPI, we had some other things. The patient doesn't have headache, no history of head trauma, no focal neurological weakness, and then the genitourinary system seems to be non-contributory because, like I said, this syndrome is probably involving the cerebellum or some other structure close to that. Uh, but so and the time course seems to be something acute. We cannot exactly define the acuity of this because the patient went to sleep early and then she wakes up, let's say maybe 6 7 hours later or 12 hours, we are not sure, but she wakes up later. She has these issues, balance as well as speech. So I'm thinking more it's vascular. And the review of systems is unremarkable. We had the patient doesn't have fever because, yes, I mean, if we talk of something, whether it's the cerebellum or any other structure, it could be anything. It could be a vascular event, it could be an infection, it could be an autoimmune process going on there, it could be a tumor. But then, based on this time course, based on other components in the HPI and then the review of systems, nothing seems to be pointing in another direction. And then coming to the past medical history, this patient is known to have hypertension. We see she's on multiple medications, including low dose aspirin as well as statins. We are not exactly sure how well the blood pressure is controlled because that's another issue. The patient is on medications, but is the blood pressure well controlled? We are not exactly sure. So I'm thinking the hypertension could be a risk factor. If at all it turns out, which is a huge consideration for me at this point. If it turns out to be a vascular event, I'm thinking the hypertension is the risk factor. So I think those are the extra details that I pick based on these other components of the history. So let's see the physical exam.
Thank you very much. So, start with general exam. So, when I saw her, oh,
You're muted, Joseph.
yeah, I'm very sorry. Yeah. So, let's start with general exam. When I saw her, she was alert and oriented. She was a febrile. She didn't have any pallor. She was not jaundice, no lymphadenopathy, and no lower limb edema. Her vital signs were unremarkable. Blood pressure was normal, pulse rate, like respiratory rate and temperature, and she was starting normal at room air. Of importance of the neuro exam, so the higher centers, she was alert and oriented to time, people, press, person, and the surroundings. She had dysarthria on the examination of the speech, and cranial nerves of particular importance was the cranial nerve number 2. She had nystagmus. The nystagmus were characteristic of when you told her to look to the right, they were right beating, and when you told her to look to the left, they were left beating. So they were direction changing nystagmus. She didn't have any ptosis. The pupils were bilateral, equal, and reactive to light. She did the extraocular muscles were intact. She also had a normal visual fields, but other cranial nerves were just normal. Motor exam power was 5 out of 5 in all 4 limbs. The deep tendon reflexes was also normal. The plantar reflex was downgoing, normal. and the sensory sensations were intact. The coordination, the finger to nose, was abnormal, and she also has this diadochokinesia. The heel to shin test was also abnormal. She walked with a wide-based gait when someone supported her, but she couldn't perform a Romberg because she couldn't stand for long. Like if you're told to stand up, she will fall down after some few seconds, so we couldn't perform the Romberg. Other systems were unremarkable.
Okay, so yes, this slide on neuro exam, I think this slide is very packed. Uh, so to begin with, we see the patient has dysarthria, as we suspected right from the history. And then this patient is having nystagmus. Uh, okay, the patient is having nystagmus. I think I'll ask this question, or I'll just wait for Joseph to teach us later. But then the patient is having nystagmus, which is direction changing nystagmus. Otherwise, Joseph hasn't told us. So yes, this nystagmus seems to be horizontal. I'm not sure if there is a torsional component or vertical nystagmus, but otherwise, other cranial nerves are normal. And then when we come to motor exam, seems to be unremarkable. Coordination, I think this is what helps us zero in probably on where exactly this lesion is. We see that finger to nose test is abnormal, heel chin test normal. So again, abnormal rapid hand movements, and then a wide based gait. So when someone has a wide based gait, we are talking of ataxia. Now, when we talk of ataxia, uh, it could be cerebellar ataxia or sensory ataxia. But then, uh, okay, I do not see. Okay, Joseph hasn't. You haven't presented any sensory exam, but I believe it was unremarkable.
So the
Uh,
intact sensorium was written there after motor.
okay. I did. Okay. I see it now. So sensory exam is unremarkable. So that means things like joint position sense, vibration, and all those other things are normal. So I think we cannot consider this ataxia to be sensory. So because I only know those two kinds of ataxia. If it's not sensory ataxia, then I'm thinking it's cerebellar ataxia. And again, I am not a neurologist, and I think I have not done a really good job in reading about balance and all that. So when it comes to coordination, I know that there are many networks that are involved, but the cerebellum is one of the major structures that are involved in coordination. So the fact that finger to nose test is abnormal, those tests of coordination are abnormal, and then we see dysarthria, we see a wide-based gait, and then nystagmus. So this nystagmus, because again we put these things together, this nystagmus, I think it's more central in origin, central in origin. So uh, Joseph didn't tell us if this patient is having vertigo. And I'm not exactly sure if someone is having any pathology in the cerebellum, it's necessary to have vertigo. But then we see nystagmus. So I think this nystagmus is central in origin, and together with all these other things, I think I'm convinced to localize this syndrome in the cerebellum. So we have something affecting the cerebellum, and now based on the acuity of the symptoms, uh, because the patient slept well, woke up with these abnormalities, I'm thinking it's most likely vascular. So yes, there are also other important considerations. I think even an infection or some inflammatory conditions can also present acutely like this. But then in the history as well as the physical examination, we do not see anything else that is pointing us in that direction. But those could be possibilities. We are dealing with, so we localize the lesion in the cerebellum most likely. And then, so what is the exact pathology now? I'm thinking it's vascular. The others that I've mentioned are differential. So I think more than that, I'll just wait for Joseph to teach me. So any labs, but I'll be waiting very eagerly for imaging to see what's going on.
Yeah, sure. And I'll give you both of them. So, as other neuro disorders, labs were unremarkable. She has a creatinine of 107. I didn't see her baseline, and also give you the MRI here. So ordered an MRI outside of my hospital. Only thing reported was brain atrophy, no focal lesions.
Okay, that's it.
Yeah, that's it.
Okay, so I did not see anything abnormal in the labs, and of course, with that mildly elevated creatinine, I think we won't waste time discussing that because I do not see any way it relates to the patient's presentation. Now, the MRI, I'm not exactly sure how many protocols were or how many uh, imaging modalities were done because we know there is T1, T2 weighted. We also have diffusion weighted, flare. So I think uh, without the specificities, I think a number of these are important in order to tell what exactly is going on.
Yeah.
So yes, I think I would be interested to hear the exact modalities. Like for example, if there is restricted diffusion, then you know there is something going on. But otherwise, we see that no focal lesions are reported. So uh, I think, especially with something that has happened in a matter of hours to 2 days, MRI, if all the modalities, I think, or if all those modalities are reviewed, properly reviewed, I think it's fairly sensitive in picking even acute ischemia, for example. So we do not hear that. I'm not exactly sure uh, which protocols were used to conclude that there are no focal lesions, but I'm still convinced. On top of my list, I'm thinking that it's a vascular event. I'm thinking it's a vascular event. Otherwise, I think I mentioned other differentials that I'm not exactly considering based on no supporting features that I picked right from the history, from the physical exam, but also labs are not exactly supportive. So I'm not sure if you have anything else, but I'm still convinced it's something vascular.
Yeah, so the MRI was pretty well done. All modalities were there, and that was it.
Okay. Yeah. So we have had an 80 years old female with a history of hypertension on medications. She's on irbesartan H, uh, esamlodipine. She's on atorvastatin, low dose aspirin, and then she's on medications for osteoarthritis, which are joint support and meloxicam. And this patient presented with a 2 days history of loss of balance with a speech abnormality that turned out to be dysarthria. Uh, so past medical history, apart from the hypertension, was unremarkable. Apart from hypertension and osteoarthritis, were unremarkable. But then when it comes to physical exam, this patient is oriented, but otherwise she had a direction changing nystagmus. She has dysarthria, and then she coordination was abnormal, a wide-based gait. Yes, I think those are the abnormalities that were picked on neuro exam. Other findings were essentially normal. So uh, I think I have some limitations here. So first of all, I think the number of differentials that I have is quite limited. It's been quite limited. I've talked about the possibility of a vascular event, and then infections as well as inflammatory conditions. I was considering them as possibilities, but especially something inflammatory, uh, we did not see any supporting labs, any supporting features in the history. But when it comes to imaging, I believe if it was something inflammatory in an MRI, some hyperintensities would be reported. So we do not hear that. And I think the same would also apply for infections. So I think my knowledge is limited on differentials and also on interpretation of this MRI, especially knowing the test characteristics with the differentials that I'm considering. But with that limited knowledge, I think we are dealing with a cerebrovascular event uh, affecting the cerebellum. That's what I'm thinking.
Yeah. Well, so I was thinking like you, but now that's the MRI. So let's see what happened. Uh, I hid one information from you. Maybe if you asked it, I could have given you. Um, so when I saw this patient, and based on his her hyperacute, because she slept and then she woke up, it's like a stroke. This thing that you're saying, and that was my thinking also, but she told me something else. So based on acute respiratory ataxia that she had and no other neuro findings, being old, I thought SMED should be the number one culprit. Why? Because they told me they went for low back pain in the clinic and they were given pregabalin. And the night she took pregabalin, in the morning she woke up with that thing. She gave me the information because I asked it. So I hid it from you because it would be so obvious. And maybe you could have, if you asked, I could have given you. And so I told this patient, I thought it's a stroke, right? Like you're saying here, which is the number one thing one should think when someone sleep and woke up with a neurological deficit. So when I sent them from an MRI outside my hospital, I told them maybe also the pregabalin is is a culprit here, so they should stop it. So you do an MRI today, you come like 2 days, they came for results, and it was gone. So it proved to me it was the pregabalin. And when the MRI was normal, I wasn't surprised. I thought it was the pregabalin. I understood that groups of these drugs can cause ataxia, but now I went on and read more and more that we will share the information here. So my diagnosis, which was proved by the fact that it started after taking pregabalin and it resolved after when she stopped pregabalin. I thought this was a pregabalin-induced ataxia. And so on my learning points, we will discuss the approach to ataxia. And again, we'll discuss the so-called pregabalin-associated movement disorders. So, but one thing that I didn't include here is, yeah, right as you're saying, when you have ataxia, it can be sensory or cerebellar, that is coming from the cerebellum or is coming from the sensorium. So you should also think of other things that are there. Like David, you're trying to see, you asked, the reason you asked, what are the sensory you mean if there are other sensory exam, for example, proprioception is impaired, this has to be probably a sensory or peripheral ataxia. But if you're seeing things like nystagmus, it has to be central. You're seeing things like dysarthria, has to be central. But yeah, so that is it. And in discussing the approach to ataxia, I have something here maybe I should share with you guys, and we can learn together. Let's see. Why is it? Yeah, I don't know. I forgot it. But so the thing is, if you have ataxia, yeah, now I see it here. Let me share it so that you can see it. It would be better. don't know. Okay. Oh, that's not what I want to do. Okay, so let's not waste our time. So if you have ataxia, the best approach to come up with the what can be causing the ataxia is to think of the timeline. To think of the timeline. So you have things like is it hyperacute, acute, subacute, or chronic? So in hyperacute, you have differential diagnosis like a stroke or medications and toxins. So it wasn't a stroke. The medications were a carpetier. Hyperacute is something that happens in minutes or seconds. See something like that, because if you don't know the duration, you assume it's hyperacute. Some, as you're told in stroke, someone who went to sleep and woke up with the neurological deficit, you assume is the stroke itself. And others, let me put back the slides. Yeah, so others will include other time durations like acute, and acute this means in days to hours to days. So we have infections of the cerebellum or inflammatory diseases of the cerebellum like multiple sclerosis flares. Subacute diseases that can affect the cerebellum will present in maybe weeks, right? So you have things like paraneoplastic syndromes or neoplasm, some slowly growing tumors, or you can have metabolic diseases like a vitamin E deficiency. But you can have chronic diseases that can affect the cerebellum. And also you have chronic medications here or toxins, which include chronic alcohol intake or phenytoin. And then you have neurodegenerative diseases of the cerebellum, things like MSA, multiple system atrophy, or some of them will be inherited, like Friedreich's ataxia, spinocerebellar ataxia, and others. So I also reviewed on pregabalin versus movement disorders, like pregabalin associated movement disorders. And it was so open, like in that review paper that I read, it more than 60% of pregabalin associated movement disorders, ataxia is the number one. And then others include things like tremors, myoclonus, Parkinsonism, and others. So yeah, this was my short case today to open the year, David.
Okay, thank you very much, Joseph. Yes, I think it's been a very interesting way to open the year. Um, so yes, I think that's one of the very important things that I missed, considering medications as a cause of the symptom. But of course, I think even if I would have done that, patients apart from things like so the drowsiness that people get from pregabalin, apart from the weight gain that they get from pregabalin, and sometimes, of course, dizziness. Patients report dizziness from pregabalin. I never knew that pregabalin can induce ataxia in people. So I think this is new knowledge added. And then, of course, this good approach to ataxia, because I think I thought about a number of differentials here, especially the vascular infections and inflammatory conditions, but I totally overlooked medications. So I think this has been a good learning opportunity, especially if things are not adding up. For example, MRI, we expected it to show some changes if there were exact pathology. So I think that should have prompted me to sit back and think what is going on. We were thinking it's vascular, and then MRI is normal. Properly done MRI is normal. So what's going on? I think that would have triggered thinking that would consider other possibilities. So thank you very much for the learning.
Sure. Yeah, we still have some time. Is there anyone with anything, any question, addition, any experience, anything that I missed, or you see it's not like you disagree with me? It's okay to disagree. It's a new year. We encourage you guys to talk here. No one. Yeah. So yeah, thank you very much, David. That was as you said, you're not a neurologist, and I don't see if you. I don't think you seeing you seeing so much. Oh, thank you, Kiara. Thank you very much. We appreciate your presence here. So yeah, David, I don't think you're seeing much neuro diseases, and it's pretty good for you as a general internist to come up with at least proper localization. Although once you localize well, you can go and open maybe up to date and find out the cause, and you will see. So yeah, otherwise it's a new year, and we promise some good other things with Afro DX, and we encourage you guys to participate. It's been like I think David, if it comes, I think March or April, it will be a year. So don't be scared. If you feel like you want to brush your brain, there are physicians here I see. Just feel free. You'll be along one of us. Not that we know much, but because we have done this, we are used to it. So hautashindwa kitu. If you are with David, for example, if you kikwama, David will take care of it, right? Yeah, and just let us know. We can give you a chance, and you can discuss a case. But if you have a case, please bring it. Like any case, even if you don't have a diagnosis, we can discuss here and maybe try to find the diagnosis. We're helping each other so that we can end up being good clinicians, all of us. Because some of you, where you are, you can't even get lectures, or you don't. There is no environment that you can learn, including me, by the way. That's why I'm doing this and learning a lot from David, who teach these things every time. Yeah, David, anything from you?
Yeah, well, so nothing else, just to echo what Joseph said. We wish to see this be more participatory, more people to participate, and I believe uh, it will be value added if someone else discusses a case one time or brings a case, because yes, as much as cases change every day, but you see our approaches, and yes, I believe we also grow, and our discussions become different every day, but then the brains are still the same. It's the same people, the same approaches. So I think if we get a chance to learn from someone else discussing a case, at least a part of it, or bringing in a different case, I think it will be more value added. So uh, just like Joseph said, I just need to reiterate that we encourage people to show interest in discussing, in bringing cases. And on top of that, if you have any suggestions or comments that you think will help improve this platform, please reach out to any of us, either Joseph or me, and we'll be more than happy to implement those. So, but otherwise, I should thank everyone. This is just the beginning of the year, but your commitment and your effort to learn has been unwavering. So I did not send any reminders today, but then people just joined. So that says a lot, that people are interested in learning. So thank you everyone for being here, because I mean, yes, as much as we've been doing it just the two of us with Joseph, but I think it's more encouraging when the other people who are joining to learn together with us. So thank you very much, everyone. We appreciate that, and yeah, we look forward to to more fun stuff this year. So good night, everyone, and we'll meet next weekend.
Good night.